Everyone, am I audible and visible? If I'm audible and visible, can I see a thumbs up, please, on the live chat? Yeah, I can see me. The INI-CET will be helpful. Yes, it'll be helpful, Juma. So, what are we going to do today? First, welcome all of you to this live YouTube session. And this is a session on PYQ trend analysis. Okay. And let me start this session with a question. The question to all of you is, if you have only 10 days, right? If you have only 10 days for the upcoming NEET PG exam, will you be studying all of biochemistry, or will you be studying only those topics which examiners love? What would be a choice? Yeah, obviously the right answer is you would like to learn about those topics which examiners love to ask. Right? So today we are not going to study biochemistry, we are going to study examiners. We are trying to understand what examiners love to ask, what examiners ask. What kind of questions do they like to frame? How do they frame those questions? What are the topics that they choose? But how are we going to do that, right? So we are going to do that. So what I have done for you is I have analyzed the last 5-year NEET PG question paper. I started with NEET PG 2021 till 2025. All papers have been analyzed by me. And what I have found out is the first analysis, the first finding. So before I start telling you all these findings, so this is not my opinion, right? This is not my abstract opinion that I'm talking to you about. This is a result of an objective audit that have been done about the last 5-year NEET PG question papers. Okay. And what I found out is the number of questions. I know this is not clearly visible here. The number of questions has not changed much. It started with 18 MCQs in 2021 till 22 MCQs in 2025. So all that you will have to observe is there is no change. There is no much of change in the number of biochemistry MCQs that are asked in NEET PG question paper. It is always hovering around 18 to 22 MCQs totally. Right? But what is strikingly here, what is strikingly that you can see here is it started with only 4 case-based MCQs. It started with just 4 case-based MCQs in 2021 till 2025. 11 MCQs. 11 MCQs were case-based MCQ, and that is what I've shown you here. This tells you about percentage of case-based MCQs and non-case-based MCQs. Can you see that there is a consistent increase in the number of case-based MCQs that have been asked previously in the last 5 years? Yeah, this is one striking finding that I've observed. And yes, this has been an opinion all along, but we have found out to be true. Yeah, we have found that out to be true. Okay. And other than that, if you see image-based MCQs, so I have categorized all these MCQs into 4 types. The first type is case-based, wherein they have given you some clinical finding, some biochemical finding, or both. And they either ask you for diagnosis or they ask you for management. In that case, that is categorized as case-based MCQ. In a case-based MCQ, even if they give you one image, I've categorized it as image-based MCQ. And whenever the MCQ involves biochemistry and pathology, biochemistry and pharmacology, biochemistry, pharmacology, and medicine, in that case, I categorize that as integrated MCQ. Other than these 3 categories, the remaining MCQs are called as factual MCQs. Okay. And as you can see here, the number of factual MCQ has decreased. It started with 8 MCQs to start with. In 2025, it is only 4 factual MCQs. So this is one finding. Now, my next finding is the heat map. What do I mean by heat map? It is topic bucket heat map. So what are the topics that have been consistently asked about in the last 5 years? Okay. And what you see here is I've categorized these as low frequency topics and high frequency topics. And can you see that vitamins and inborn errors of metabolism have been frequently asked? Starting from 2021 till 2025, there has been no change. These topics are frequently asked about. Okay, so that's about vitamins and inborn errors of metabolism. And apart from that, do you see that consistently they've been asking you questions on lipids and core metabolism? So by core metabolism, what do I mean? If they ask you a question about what happens in fed state, what happens in starvation, they're asking you about effects of hormones. Those have been categorized as core metabolism. So lipids and core metabolism, moderately they've been asking, and it is consistent. Okay, and as I showed you in the first slide, there is a steady state increase in the number of clinical biochemistry. What do I mean by clinical biochemistry? Suppose there is an MCQ on calcium estimation. Tourniquet application for calcium estimation was prolonged. What is the effect? Or they ask you question on blood collection tubes, right? They ask you about order of draw. They ask you about which tube is used for which analyte, or arterial blood gas analysis, or renal function test, liver function test, right? So these are the subtopics which are categorized as clinical biochemistry, and this number has consistently increased. And what is striking here is genetics. There is a steady state increase in the number of genetics MCQs also in the last 5 years. Also enzymes, even enzymes, there is a steady increase. This we all know, right? Don't you know that in enzymes, they've started asking you many graph, right? Competitive inhibition, uncompetitive inhibition, non-competitive inhibition, or the type of enzyme, or electron transport chain inhibitor. That is the last category of topic. So these are the topics that have been frequently asked about. So if you ask me to summarize the trend analysis that I've done, okay, the summary of the trend analysis is, as I told you, type of MCQ, case-based MCQ is now the default. In any paper, there is an increase in the number of case-based MCQ that are asked, which means factual learning of cycles, factual learning of pathways will not just help you. You should progress from cycles and pathways to applied aspects. That goes without saying, right? That is the first observation. The next observation is consistently they've asked you questions on vitamins, inborn errors of metabolism in high frequency. Number of MCQs also more for these two topics. Consistently, they've asked you questions on lipids. What do I include under lipids? Dyslipidemia. Have you been seeing MCQs on dyslipidemia? Type 1 hyperlipoproteinemia, type 2A hyperlipoproteinemia, glycosphingolipidosis, right? So those are categorized as lipids. So lipids and core metabolism, consistently they've asked, but in moderate frequency. Okay. Clinical biochemistry and genetics, there is a sharp rise. So what did I tell you is included under clinical biochemistry? Function test, electrolyte analysis, tourniquet application, pre-analytical variables. What are the blood collection tubes that are used for what purposes? What is the order of draw? So all these, this is spiking. So this is my observation. This is the trend analysis report, right? Do you all understand this? Biochemistry is not confusing, Ashima. It is simple. So watch this session, because it's not just a Gyan session wherein I'm going to just tell you what you can expect. I'm also going to teach you few biochemistry topics on the go. Right? When I say on the go, all these topics, I will be telling you clinical triads that you should remember, clinical clues that you should remember, the clue grid that you should have in your memory, what to do when it's an image-based question. So all these concepts will also be taught today. So watch this session. Okay. So this is the result of trend analysis. Okay. Now comes the $1 million question. So tell me, what is a $1 million question? I'm going to tell you all about that. All of you, as always, don't get into the fear of missing out mode. No FOMO today. Okay, I want you to just listen to what I'm telling you. I will be covering all topics, in the sense I will tell you what are the subtopics that have been asked previously, what are the subtopics that you should prepare for this upcoming NEET PG exam. So rest assured, right? So keep that trust on me. Okay, so I'm going to repeat this. These days, I've been repeating this multiple times. This is my 20th year teaching medical post-graduation aspirants. So I know what you're looking for. Okay, so trust me and watch this session. Okay, so this is about the trend analysis. Now, the $1,000,000 question, the $1,000,000 question is, if I am going to teach you 6 topics. Okay, if I'm going to teach you 6 topics, what are the topics that I would like to cover? I would like to cover those 6 topics which have been frequently asked before. So what are those topics? Obviously, number 1 would be inborn error of metabolism, right? I'm going to definitely tell you few facts that you should remember about inborn errors of metabolism. And then number 2 is vitamins. That also goes without saying, right? So inborn errors of metabolism, vitamins and micronutrients. And this should be followed by clinical biochemistry. Mainly because there are not many textbooks which cover about clinical biochemistry. So I will have to teach you about clinical biochemistry, which includes ABG electrolytes. Okay. And then the 4th topic that I would definitely cover is lipids and dyslipidemia with glycosphingolipidosis. Okay. Then we have to cover genetics, right? Obviously, we need to know about genetics and molecular biology. And the last topic that I would like to discuss about is core metabolism. So these are the priority topic clusters. Okay, these are the priority topic clusters that you should learn or I should teach you. Okay, now I'm going to cover all these 6 topics and the relevant subtopics. Let's start with inborn errors of metabolism. Okay, so all of you listen to this. I don't think I'll be able to cover the entire topic, right? Entire mucopolysaccharidosis. That is not the aim of this session. But what I can tell you is what are the salient features that you should remember regarding mucopolysaccharidosis that you should be able to answer. Okay, so listen to this. So as far as inborn errors of metabolism are concerned, what are the key disorders that you should remember or learn about? Obviously, number 1 is Tay-Sachs disease. Okay, so what are the key features that you can expect Tay-Sachs to be the answer? Right, Tay-Sachs to be the answer when there is a case-based MCQ. They would definitely tell you that there is cherry red spot, right? Cherry red spot without organomegaly with neurological involvement. Do you understand this? So can you repeat this? Whenever it says cherry red spot, no organomegaly, neurological involvement, then what should be your answer? Your answer should be Tay-Sachs disease. Also remember, Tay-Sachs disease is otherwise called as GM2 gangliosidosis. Now your question to me should be, what if they give you cherry red spots with neurological involvement with organomegaly? If there is organomegaly also, then your diagnosis should be Niemann-Pick. Do you understand this? Then your answer should be Niemann-Pick disease caused by the defect of sphingomyelinase. So this is a shortcut that you should remember as far as Tay-Sachs disease is concerned. Okay. What if it's Gaucher's? Very good. I'm happy that all of you are answering. So when will you suspect Gaucher as the answer? Right? So if they give you an image based question and if the image says crumpled tissue paper appearance. So what can you see as crumpled tissue paper? They would give you a histopathological examination. A slide will be shown. A blue color cell is seen, right? A blue color cell is seen with fibrils, right? With fibrils. Then that is called as crumpled tissue paper appearance. This is not the only phrase that you should look for. You should also find out if the child presents with anemia, right? Anemia, thrombocytopenia. Are you all listening? Anemia, thrombocytopenia, crumpled tissue paper appearance, knee pain. The child will complain of bony pain. And if they give you Erlen-Meyer-Flask deformity, right? Erlen-Meyer-Flask deformity. In all these cases, if you see all these, a few of these findings, then what should you suspect? You should suspect Gaucher's disease. Are you clear? Gaucher's disease. Please remember, Gaucher's disease is caused by the defect of which enzyme, all of you? Beta-glucosidase or beta-glucosyl cerebrosidase. right? Beta glucosidase or beta glucosyl cerebrosidase. So these are the facts that you should remember as far as Gaucher's disease. So when will you suspect Gaucher's disease? Remember crumpled tissue paper appearance on histopathological finding, anemia, thrombocytopenia, knee pain, Erlen-Meyer-Flass deformity on X-ray. In all these cases, please suspect Gaucher's disease caused by the defect of beta glucosidase. Okay. Now, Hurler's. When will you suspect Hurler's disease? You should first remember that it is a mucopolysaccharidosis. And when will you suspect mucopolysaccharidosis? Whenever the history says gargoylism, right? Whenever the history says gargoylism. What is gargoylism? Coarse facial features. So somebody asked about mucopolysaccharidosis. So when will you suspect mucopolysaccharidosis? Whenever they say coarse facial features with short stature. Please remember short stature with depressed nasal bridge. Okay, with depressed nasal bridge with organomegaly. Right, with organomegaly. In all these cases, suspect mucopolysaccharidosis. Now, what is Hurler syndrome? Hurler syndrome is, please remember, it is mucopolysaccharidosis type 1. Right? So, type 1 is Roman letter 1 is the alphabet I. Roman letter 1 is the alphabet I. It is caused by the defect of L-iduronidase. It is caused by the defect of which enzyme? L-iduronidase. Okay, so how will you differentiate type 1 from type 2? Can you all answer? What is type 2, everybody? Let me write down type 2 in yellow color. Type 2 is Hunter's. Okay, I've told you so many times, type 1s are always severe. So whenever the condition is severe gargoylism, organomegaly, significant hepatosplenomegaly, massive hepatosplenomegaly, abdominal distension, inguinal hernia, mental retardation. So all that would be a severe condition, which is type 1, which is Hurler's. Type 2, similar finding. Again, gargoylism, coarse facial features, short stature, depressed nasal bridge, organomegaly. But it is milder, it is Hunter's. And I told you in Hunter's, you don't see corneal clouding. Remember? Hunter's, you don't see corneal clouding. I said a Hunter's vision has to be perfect. So no corneal clouding, no inguinal hernia. Right? No corneal clouding, no inguinal hernia caused by the defect of iduronate sulfatase. It is caused by the defect of iduronate sulfatase. L-iduronidase defect is type 1. Iduronate sulfatase defect is type 2. So if you remember this, that is enough as far as mucopolysaccharidosis type 1 and type 2 are concerned. Right? So when will you suspect mucopolysaccharidosis? If they say cherry red spot, exclude mucopolysaccharidosis. Right? Because cherry red spots are seen in lipid storage disorders. Only when lipids accumulate, you see cherry red spot. The moment you see cherry red spot, what will you exclude? Mucopolysaccharidosis. When will you include mucopolysaccharidosis? Whenever you see gargoylism. And if they say there is corneal clouding, it is Hurler's. No corneal clouding, it is Hunter's. Do you understand this? So that's about Hurler's and Hunter's. Okay. Hernia is not seen in Hunter's. Okay. Now, when will you suspect Pompey's disease? How did I ask you to remember this? Pompey's, the pump is affected. Which is the pump of your body? Heart. Right? So in Pompey's, the pump is affected, the heart is affected. Whenever they say cardiomegaly, right? Whenever they say cardiomegaly or cardiomyopathy or heart failure. Okay. Along with this, please also remember the skeletal muscle is also affected. Not only cardiac muscle, skeletal muscle is also affected. So it presents as hypotonia. So how many of you are expecting video-based MCQ in your exam? Right? If you are expecting a video-based MCQ, please say yes on the live chat. Most of us are expecting video-based MCQ in the upcoming NEET PG exam for many reasons, because they've started asking in FMG And then this time they've reduced the number of MCQs to 180. So there is a very high probability that they add a video-based MCQ. For a video-based MCQ, they can ask you about Pompey's disease. Stay with me. I will be showing you a video for Pompey's disease. I'm going to discuss few video-based questions also. Okay. So wherein if you see a floppy baby, right? Whenever you see a floppy baby with cardiomegaly, cardiomyopathy and heart failure, what should you suspect? You should suspect Pompey's disease. And Pompey's disease is caused by the defect of alpha glucosidase. Pompey's disease is caused by the defect of alpha glucosidase. So remember, beta glucosidase defect. Always compare, contrast and learn. Okay, so compare, contrast. Gaucher's is caused by the defect of beta glucosidase. Pompey's is caused by the defect of alpha glucosidase. So whenever they show you an image, right, X-ray shows cardiomegaly and there is hypotonia. What will be your answer? Pompey's disease. A video-based question wherein they are showing you parachute reflex being missing. What is parachute reflex? If you're holding the baby by the belly, right? If you're lifting the baby by the belly, you should see all four limbs to go up and the neck should be lifted. That is normal parachute reflex. If there is no normal parachute reflex and the baby is hanging down, right? That is a floppy baby. So that is a video-based MCQ that can be asked. Floppy baby with cardiomegaly is Pompey's disease caused by the defect of alpha glucosidase or acid maltase. Okay, alpha glucosidase or acid maltase. So these are the four subtopics as far as lysosomal storage disorders are concerned. Okay, now amino acids. If you look at amino acids, as you all know, phenylketonuria has been repeatedly asked about, right? And there is a catch here. Listen to this, there is a catch here. If it's phenylketonuria, the most common cause of phenylketonuria is phenylalanine hydroxylase defect, right? Which enzyme defect causes phenylketonuria? It is phenylalanine hydroxylase defect. In that case, what would you see? In that case, you would see mental retardation. The history would say a child presents with delayed milestones and mental retardation with mousy odor, right? What will you see? Mousy odor. If you're all asking me, how do I remember that mousy odor is seen in phenylketonuria? Ketonuria key, right? Ketonuria key. Mouse. In a computer, right? In a computer, don't you know that there is a keyboard and there is a mouse, right? Keyboard and mouse. So phenylketonuria key, mousy odor. Okay, so whenever the history says mental retardation, mousy odor, hypopigmentation, right? Hypopigmentation. What will you suspect? You will suspect phenylketonuria caused by phenylalanine hydroxylase defect. Okay. Along with that, all of you please watch this carefully. Here is the catch. Along with that, if you see seizures, right? If you see seizures, then it could be malignant phenylketonuria. In that case, what is your diagnosis? That is malignant phenylketonuria, not caused by phenylalanine hydroxylase defect, but it is caused by the defect of dihydrobiopterin reductase enzyme. It is caused by the defect of dihydrobiopterin reductase enzyme. Now, this is an enzyme which is necessary for phenylalanine hydroxylase, tyrosine hydroxylase, tryptophan hydroxylase. Please repeat, dihydrobiopterin reductase is necessary for the activity of phenylalanine hydroxylase, tyrosine hydroxylase and tryptophan hydroxylase. So many enzymes are inactive in this condition. In that case, the presentation will be severe. So they don't just present with mental retardation, mousy odor, hypopigmentation as expected. Additionally, there is also seizures. And classically in the question, they would say phenylalanine hydroxylase activity is normal. They would say phenylalanine hydroxylase activity is normal. In that case, your answer should be malignant phenylketonuria caused by the defect of dihydrobiopterin reductase. Okay, so that's about phenylketonuria. Now the next disorder is homocystinuria, right? So when will you suspect homocystinuria? You have to suspect homocystinuria whenever they say accelerated atherosclerosis, right? Accelerated atherosclerosis, accelerated thrombosis. Okay, they also see ectopia lentis. They also say that there is ectopia lentis. All of you remember infranasal dislocation of lens, right? Whenever they say infranasal dislocation of lens. Okay, so if you see all these features, then what will you suspect? You would suspect homocystinuria. Do you all understand this? So when will you suspect homocystinuria? Accelerated atherosclerosis, accelerated thrombosis, infranasal dislocation of lens. Which means when will you, what will be your diagnosis if there is superolateral dislocation of lens, superotemporal dislocation of lens? Bilateral superotemporal dislocation of lenses, Marfan syndrome. Marfan syndrome is also frequently asked about, right? It is also frequently asked about a tall individual with a long face, with a long arm span, presents with superotemporal dislocation of lens. Then what is your diagnosis? Marfan syndrome, okay? Caused by which gene mutation, all of you? Fibrillin gene mutation. Marfan syndrome is caused by fibrillin gene mutation. So that's about homocystinuria. Okay. So now about alkaptonuria. I can hear you all answering. Alkaptonuria. Alkapton means black. Alkaptonuria is black urine disease. So whenever they say urine turns dark on standing, right? Whenever the history says urine turns dark on standing. And if they talk about euchronosis, what is euchronosis? Multiple joints are involved, right? They say knee pain, ankle pain, elbow pain, multiple intervertebral disc bulges, and the urine turns dark on standing. In that case, what will be your diagnosis? Your diagnosis will be alkaptonuria. I'm going to wait for you to type on the live chat the enzyme that is defective. So tell me which enzyme is defective in alkaptonuria. The enzyme that is defective in alkaptonuria is homogentisate oxidase, right? Homogentisate oxidase. Also remember, alkaptonuria answers Benedict's test, right? Alkaptonuria answers Benedict's test. They are treated with mega doses of vitamin C. Alkaptonuria is treated with mega doses of vitamin C, or you can give nitisinone. You can also give nitisinone. Do you all understand this? So these are the facts that you should remember as far as alkaptonuria is concerned. Now the next one is Lesch-Nyhan syndrome. I am very happy that most of you have answered it right. So Lesch-Nyhan syndrome. This is a favorite topic of mine. Because there is a mnemonic for Lesch-Nyhan syndrome, and the mnemonic is leash, right? What is it? Leash. What does L stand for here? L stands for lips are bitten, right? Lips and nails are bitten, which we call as self-mutilation, okay? E stands for elevated uric acid. They present with hyperuricemia. S stands for self-mutilation. So this can be given as a video-based question, right? What if they show you a video wherein the child is biting the lip, biting the nail, okay, and you see that everything is bitten. And you also see chorioathetosis. C stands for what? Chorioathetosis. H stands for HGPRTase deficiency. Okay, H stands for HGPRTase deficiency. Can all of you type this in the chat box? What is HGPRTase? Hypoxanthine guanine phosphoribosyl transferase. Right? Hypoxanthine guanine phosphoribosyl transferase deficiency. It's an enzyme of purine salvage pathway. So all of you repeat this along with me. For Lesch-Nyhan syndrome, what is the mnemonic? It is there in the name Lesch. What does Lesch stand for? Lips and nails are bitten. elevated uric acid, the child presents with hyperuricemia, self-mutilation, you see chorioathetosis, and then HGPRTase enzyme defect. Very good, Dhanush. Okay, so that's about Lesch-Nyhan syndrome. Now about McArdle's disease. When will you suspect McArdle's disease? Whenever they say exercise intolerance, right? Whenever they say exercise intolerance, intolerance particularly to anaerobic exercise, right? Intolerance particularly to anaerobic exercise, wherein clenching the fist causes muscle spasm, right? And then they say post-exercise, blood glucose is low, blood lactate level is low. Yeah, in that case, what will be your diagnosis? Your diagnosis will be McArdle's disease. What is McArdle's disease due to? McArdle's disease is because of the defect of muscle phosphorylase. Right, McArdle's is because of the defect of muscle phosphorylase. Because muscle phosphorylase is defective, what do you expect in this child? You expect in this child exercise intolerance particularly to anaerobic exercises. Post-exercise, blood glucose and blood lactate levels are low. Okay. Now, when will you suspect von Gierke's disease? Can anybody tell me what is pathognomonic for von Gierke's disease? You should suspect von Gierke's disease whenever the history says severe fasting hypoglycemia, right? Severe fasting hypoglycemia, which does not respond to counter-regulatory hormone administration. Okay, I won't be able to explain the reason behind all this because this is like a high yield session where I'm going to bombard you with facts and you're going to memorize all these facts. Keep this in your memory. And the moment you see it, these are the classical clues, right? These are the classical catchy phrases that should immediately give you the diagnosis. Okay, that is the purpose of the session. So I'm not going to get into the details. All that you will have to know is von Gierke's disease should be suspected whenever the history says severe fasting hypoglycemia, which never responds to counter-regulatory hormone administration. Okay, and if it says doll-like faces, all of you, please memorize it. What is doll-like faces? This is von Gierke's disease. Okay, and the child presents with hypertriglyceridemia, lactic acidosis. Okay, lactic acidosis, hyperuricemia. Okay, so if you see all these features, a chubby child, doll-like faces means a chubby child with abdominal distension because of hepatomegaly and renomegaly. Do you understand this? A chubby child with abdominal distension because of hepatomegaly, renomegaly, presenting with severe fasting hypoglycemia, which does not respond to counter-regulatory hormone administration, with hypertriglyceridemia, that is why chubby cheeks. Okay, hypertriglyceridemia, high lactic acid, high uric acid, then suspect von Gierke's disease. All of you tell me which enzyme defect causes von Gierke's disease. Von Gierke's disease is caused by the defect of glucose 6-phosphatase. Do you understand? It's caused by the defect of glucose 6-phosphatase. So these are the key disorders. Okay, so these are the key disorders that have been frequently asked about in the last 6. Actually, I checked even an year before, but I would say honestly speaking, I did a detailed analysis from 2021 to 2025. So in the last 5 years, these are the topics as far as IEM is concerned, which have been repeatedly asked about. So have all these topics in your mind, and the day before exam, these are the topics that you should quickly revise. Okay, so that's all about inborn error of metabolism. Okay, no, I will be discussing about inborn error of metabolism more when I start giving you about the clinical triads that you should remember. Okay, so one topic is discussed. Now comes vitamins, right? So as far as vitamins and micronutrients are concerned, these are the subtopics that you should know. These are the subtopics that have been asked before. Okay, so as you know, niacin, What is niacin? Niacin is vitamin B3, right? Niacin is vitamin B3, and vitamin B3 deficiency causes 3 Ds of pellagra. What are the 3 Ds of pellagra? Whenever they say diarrhea, dermatitis, dementia. Okay, diarrhea, dermatitis, dementia. So whenever they say these 3 Ds, okay, diarrhea, dermatitis, dementia, think of vitamin B3 deficiency or niacin deficiency. And along with that, there is a possibility that they give you a dietary history. They can say that these people are on a maize-based diet, right? Maize-based diet. Because tryptophan availability from maize is low, if you're on a maize-based diet, then you're prone to develop pellagra. Okay. Now, diarrhea dermatitis is also a feature of zinc deficiency. So have you all heard of acrodermatitis enteropathica? Right? Acrodermatitis enteropathica. So what is acrodermatitis? Perioral, perianal dermatitis in the periphery, around the orifice, right? Around orifices, if there is dermatitis, don't go and say it is B3 deficiency. In B3 deficiency also there is dermatitis, but that dermatitis is Castle's necklace, right? Hyperpigmented lesions in the sun exposed area. That dermatitis is niacin deficiency or pellagra. But if they say periorificial dermatitis, think of zinc deficiency, acrodermatitis enteropathica. So here also you see diarrhea. And additionally, they always talk about hair loss, alopecia. So if you see these 3 features, that is zinc malabsorption, zinc transporter defect, which is called as acrodermatitis enteropathica. Okay. Now about vitamin C deficiency. When will you suspect vitamin C deficiency? Whenever they say poor wound healing, right? If they say poor wound healing with bleeding gums, I don't know, yeah, with bleeding gums, okay, with petechiae. So what is common here? In bleeding gum and petechiae, it is superficial bleeding. And additionally, they would also say heme arthrosis is absent. What do you mean by heme arthrosis being absent? There is no deep bleeding. There is no bleeding into the joint. Do you understand? There is no deep bleeding, only superficial bleeding. So whenever they say poor wound healing with bleeding gums and petechiae, no heme arthrosis, then you should suspect vitamin C deficiency. Are you clear? And if they ask you why should vitamin C deficiency present with all these manifestations? Because vitamin C is necessary as a coenzyme for, please answer, it is necessary as a coenzyme for prolyl hydroxylase, yeah, prolyl hydroxylase and lysyl hydroxylase. It is necessary as a coenzyme for prolyl hydroxylase and lysyl hydroxylase, both of which are involved in post-translational modification of collagen. So when collagen is not matured, wound healing does not happen. When collagen is not matured, blood vessels are not supported. When blood vessels are not supported, you see superficial bleeding, bleeding gums, petechiae, heme arthrosis not seen. Okay. Whereas if they say heme arthrosis is seen, yeah, heme arthrosis seen, you see deeper bleeding. Yeah, deeper bleeding, then that is vitamin K deficiency. Why should vitamin K deficiency cause deep bleeding? Because vitamin K is necessary as a coenzyme for which enzyme, all of you? Vitamin K is necessary as a coenzyme for, please answer, gamma carboxylase. What is the use of gamma carboxylase? It is necessary for post-translational modification of vitamin K dependent clotting factors. Tell me, what are the vitamin K dependent clotting factors? These can be factual MCQs. Vitamin K dependent clotting factors are clotting factor 2, 7, 9, 10. When these clotting factors get affected, extrinsic pathways affected. When extrinsic pathways affected, PTINR, right? PTINR will be elevated. So if you see all these all this is simple, right? All this is simple. It's just that you will have to revise it multiple times. I always say this, eyes do not see what the mind does not know. You understand this? Eyes do not see what the mind does not know. If you don't keep revising this multiple times, and if your mind does not know it, even if these classical phrases are there in the question, you will not be able to see it. When you come out of the exam hall, when your friend discusses about this, then you will be like, oh my God, I should have found this out. I should have seen it. I missed it. It is not like you missed it on the day of exam. You missed the day before the exam to revise. Do you understand this? So eyes do not see what the mind does not know. So keep revising this multiple times. So whenever it says deeper bleeding heme arthrosis, suspect vitamin K deficiency, because vitamin K is necessary as a cofactor for gamma carboxylase enzyme, which is necessary for activating clotting factors 2, 7, 9, 10. When those clotting factors are not activated, extrinsic pathway is affected, PT-INR is increased. Okay, so that's about vitamin C and vitamin K. Okay, now about vitamin B12. Okay, so if you look at B12, when will you suspect B12 deficiency? Whenever they say a vegan, right, you should suspect B12 deficiency whenever the dietary history says the person is a vegan, because B12 sources are non-vegetarian sources. Okay, a vegan presents with macrocytic anemia. Do you understand this? A vegan presents with macrocytic anemia and neurological manifestations. I want your utmost attention here, right? With neurological manifestations. In that case, you should suspect B12 deficiency. What are the neurological manifestations that you can expect here? They would say peripheral sensory neuropathy. Pins and needle sensation, tingling sensation in the periphery is how it starts. Then it affects a posterior column. Don't you all know that posterior column is related to fine touch sensation, proprioception, right? What is proprioception? Joint position, right? So proprioception, vibration sense. So initially it starts as peripheral sensory neuropathy, wherein they present with tingling sensation in the periphery. That is followed by posterior column getting affected. Then posterior column gets affected. They don't have fine touch sensations. They don't have joint position sense, right? They don't have vibration sense. And then finally, it also includes corticospinal tract. Not only sensory tract, it also involves corticospinal tract. That is when it is called as subacute combined degeneration. So what is subacute combined degeneration? Please tell me. It is called as subacute combined degeneration because not only sensory pathway, which sensory pathway is affected? Posterior column is affected. Not only sensory pathway, motor pathway is affected. Which motor pathway? Corticospinal or pyramidal tract is also affected. Okay, in that case, what will you see that as? All of you watch this. This can be a video based question. Do you get it? This can be a video based question where you're shown a child or a person walking with a broad stance. Okay, they're walking with a broad stance and then they are giving more force when they hit the floor. Okay, louder feet, louder steps. Okay, so broader stance and louder steps. Okay, along with that, you also see a spastic gait. Why do you see broader stance? Because there is no joint position sense. So they don't even know where their joint is in the space. So approximately they are landing their feet on the floor. So broader stance with loud steps with spastic gait. Okay, with spastic gait. And you also see Babinski sign to be positive. Why Babinski sign? Corticospinal tract is involved. Right? When upper motor neuron is involved, there is Babinski sign. So these can be given as a video based question. So there is a case based MCQ and then there is a video along with it. The video shows a broader stance with louder steps, spastic gait. You're shown Babinski sign. And then the history says a vegan presenting with macrocytic anemia. Which deficiency is the right answer? B12 deficiency. Are you all clear? Yeah, so that is about B12 deficiency. Now, when will you suspect folate deficiency? You will have to suspect folate deficiency whenever it says again macrocytic anemia, okay, no neurological manifestations. Do you understand this? No neurological manifestations. And here the person is on a strict non-vegetarian diet. The person is on a strict non-vegetarian diet because folate is seen in green leaves. So if the person is on a strict non-vegetarian diet, then you should suspect folate deficiency. So that is about how to differentiate folate deficiency and B12 deficiency. Okay. Now thiamine. Again, frequently asked topic is thiamine deficiency. So this we all know. They often say there is a chronic alcoholic. Okay, so I will tell you about chronic alcoholism under clinical biochemistry also today. But for now, whenever they say chronic alcoholic presenting with neurological manifestations, then suspect thiamine deficiency. And acute thiamine deficiency is called as Wernicke's encephalopathy, right? Acute thiamine deficiency is called as Wernicke's encephalopathy. All of you tell me, what is a mnemonic that you should remember? What is a mnemonic that you should remember for Wernicke's encephalopathy? GOVA. What does GOVA stand for? Global confusion, ophthalmoplegia, ataxia. That is acute thiamine deficiency. Chronic thiamine deficiency is Korsakoff syndrome. And when will you suspect Korsakoff syndrome? Whenever you see the term amnesia. An alcoholic presenting with retrograde amnesia, anterograde amnesia with confabulation. In that case, it is chronic thiamine deficiency, which is Korsakoff syndrome. Okay, so these are the classical facts that you should remember as far as vitamins and micronutrients are concerned. Okay, so whenever you see poor wound healing, what will you suspect, all of you? Poor wound healing is either zinc deficiency or vitamin C deficiency. Okay. Whenever you see macrocytic anemia, it is either folate deficiency or B12 deficiency. Whenever you see bleeding, it is either vitamin C deficiency or vitamin K deficiency. Okay. I hope it's clear to everybody. I hope this helps. Yep. So that's about the second topic. Okay. Now the third topic. Yeah, biotin. Biotin is, the history will be classical. They would say a person, a gym trainer, right? A gym trainer who consumes 6 egg whites, raw egg whites every day to build muscle. And that person is presenting with hair loss and dermatitis. With hair loss and dermatitis. In that case, what would you say? Biotin deficiency, because raw egg white is rich in avidin. Avidin binds biotin, causing biotin malabsorption. So whenever they say raw egg white consumption, there is avidin which causes biotin malabsorption, that causes dermatitis and alopecia. Okay. Now the third topic, right, which is clinical biochemistry. So in clinical biochemistry, I'm going to just tell you the 4 steps. Again, this is a revision, right? Because I've told you all about this in LRR, right? So what are the 4 steps that you need to follow for ABG interpretation? Okay, so these are the clinical biochemistry key scenarios that have been asked in the last 5 years. So what are the subtopics? They have often asked you about ABG, as you know. They always ask you about pyloric stenosis. What is the abnormality, right? What is the electrolyte abnormality that you see in pyloric stenosis? What is the ABG, right? What is the acid-base abnormality that you see in pyloric stenosis? And they often ask you about hyperventilation. What is the effect of hyperventilation? Why should hyperventilation cause carpopedal spasm? This has been asked twice. Okay. And then they ask you what happens in starvation. And then, as I told you, alcohol. Okay. As a quick recall about all these. Okay. Which will be complete in the next 5 to 10 minutes. Okay. So first about ABG interpretation, what are the 4 steps, right? What are the 4 steps I told you should follow for interpreting any ABG report? Step number 1 is to check the pH. Can you all type normal values? All of you, what is a normal pH? Please type it in the chat box. Normal pH is 7.36 to 7.44. What is a normal PCO2? Normal PCO2, take off the 7. What are you left with? 36 to 44 millimeters of mercury. Normal PCO2 is 36 to 44 millimeters of mercury. What is the normal bicarbonate? The normal bicarbonate is 24. On either side, you have 3. So the range is 21 to 27 milliequivalents per liter. Right? The range is 21 to 27 milliequivalents per liter. Right? So these are the normal values that you should know by heart. Now, what are the 4 steps that need to be followed? Step number 1, to find out whether it is acidosis or alkalosis, check the pH, right? Which is quite obvious. Step number 1, check the pH, find out whether it is acidosis or alkalosis. You know the range. If it's less than 7.36, it is acidosis. If it is more than 7.44, it is alkalosis. Step number 1, done. Step number 2, check bicarbonate and PCO2. Why should you check bicarbonate and PCO2? To find out whether it is metabolic or respiratory. So tell me, what is step number 2? Step number 2 is to check bicarbonate and PCO2 to find out whether it is metabolic or respiratory. Okay. Suppose the pH is low. Okay. We know it is acidosis. And if this acidosis is accompanied by a low bicarbonate, if this acidosis is accompanied by a low bicarbonate, then what is your diagnosis? Your diagnosis is metabolic acidosis. If this acidosis is accompanied by a high PCO2, because carbon dioxide is an acid. Just remember this, don't forget it. Carbon dioxide is an acid. So whenever carbon dioxide accumulates, that causes acidosis. That is called as respiratory acidosis. Got it? That's called as respiratory acidosis. Now, what if the pH is high and you know it is alkalosis? If this alkalosis is accompanied by high bicarbonate, if this alkalosis is accompanied by high bicarbonate, that is called as metabolic alkalosis. If that is accompanied by low PCO2, okay, so if that is accompanied by low PCO2, that is called as respiratory alkalosis. Do you understand this? So this is about step number 2. What is step number 2 for? To find out the primary acid-base disorder. So to find out the primary acid-base disorder is metabolic or respiratory, check bicarbonate and PCO2. Okay. Now step number 3. Step number 3 is to calculate compensation. After you find out the primary acid-base disorder, you have to check compensation based on the primary acid-base disorder that you have diagnosed. Okay. And for that compensation, for want of time now, I want you to remember only one simple fact. Compensation is always parallel. Do you understand this? Compensation is always parallel. Meaning, if the primary defect is a decrease in bicarbonate, if the primary defect is a decrease in bicarbonate, the compensation is a decrease in PCO2. Do you understand this? The compensation is a decrease in PCO2. If the primary defect is an increase in PCO2, please tell me what is the compensation? Compensation is an increase in bicarbonate. So the compensation is always parallel. Along with the primary disorder, if the primary defect is metabolic, lungs compensate. If the primary defect is respiratory, kidneys compensate. The compensation is always parallel. So see if there is a parallel shift. If there is a parallel shift, you say there is a compensation. Okay. So that's about step number 3. With step number 3, you're done. Okay. When will you go to the last step? I told you in LRR session, you should go to the last step only when it is metabolic acidosis. Only when it is metabolic acidosis, you calculate anion gap. right? What do you calculate? You calculate anion gap. Why do you calculate anion gap? To find out the cause of metabolic acidosis. Do you understand this? Why do you calculate anion gap? To find out the cause of metabolic acidosis. If anion gap is high, right? If anion gap is high, I'm going to tell you something, memorize it. If anion gap is high, it means metabolic acidosis is because of production of an abnormal acid. It means metabolic acidosis because of production of an abnormal acid. The abnormal acid can be lactic acid. The abnormal acid can be uric acid, right? It can be any other acid like ethanol, methanol, and ethylene glycol poisoning. Any alcohol poisoning. These are the suspicions that you should have in your mind when the anion gap is high. Okay. What if the anion gap is normal? If the anion gap is normal, then the metabolic acidosis is because you have lost your bicarbonate. If the anion gap is normal, it is because of loss of bicarbonate either through GIT or through kidney. Through GIT, when will you lose bicarbonate? Diarrhea, right? Through kidney, when will you lose bicarbonate? Renal tubular acidosis. Okay, so why do you calculate anion gap? Can you all repeat this? Can I see the chat box to be active? So whenever I start discussing biochemistry facts, okay, people stop dropping. So people only want to know, they only want to know what is a trend, what should I learn, but they're not ready to learn. Okay, that's quite interesting. So only those who can overcome that, okay, those who have that patience, right? Only those who have that patience to listen, understand, and memorize will be successful. Okay, so I want all of you to listen to this. Is this like a high yield session? At the end, you would have covered almost all topics in a nutshell, and this cannot happen otherwise. Okay, so quickly go through this. Show your perseverance, show your grit, sit through the session, and at the end you will know that you have learned so many facts and so many concepts, right? So we have put enough efforts into conducting the session, right? Nobody is going to penalize us if we don't conduct this session. We are doing it because we want as many students as possible to be benefited out of this. Okay, so watch this session. This will be of help to you. So what if anion gap is high? The one fact that you should remember is if anion gap is high, metabolic acidosis is because of some abnormal acid is getting generated. The abnormal acid that is getting generated can be keto acid, right? It can be a keto acid, or it can be a lactic acid. It can be uric acid, or it can be ethanol, methanol, or ethylene glycol poisoning. If the anion gap is normal, okay, then check whether it is diarrhea. Diarrhea, please remember, presents with what condition? Diarrhea presents with normal anion gap metabolic acidosis. If the anion gap is normal, if there is no diarrhea, then it is renal tubular acidosis. This is like a very summary, very core summary of what anion gap is for, what is it used for. Okay. I'm happy that you're all liking this session. Okay. So this is about the 4 steps. So to summarize about 4 steps, what is step number 1? Everybody check pH, find out whether it is acidosis or alkalosis. Step number 2, check bicarbonate and PCO2, find out whether it is metabolic or respiratory. You have found out the primary acid-base disorder. Step number 3, calculate compensation. Step number 4, calculate anion gap only when it is metabolic acidosis. Okay, so I'm going to ask you to solve this. Can you try solving this example, right? What is the value that is given? pH is 7.2. All of you start answering. What is the normal pH? 7.36 to 744. So here the pH is low. So what is your diagnosis? Low pH is acidosis. Okay. After this, check PCO2. What is the PCO2 that is given here? 80. What is the normal PCO2, everybody? Normal PCO2 is 40. So from 40, it has become 80. So PCO2 is high. If carbon dioxide is high, that causes acidosis. And what do you call that acidosis as? You call that acidosis as respiratory acidosis. Do you understand this? So what is your diagnosis? It is respiratory acidosis. Step number 3, check compensation. I said compensation should be parallel. Meaning, if PCO2 is high, the compensation is an increase in bicarbonate, right? The compensation is an increase in bicarbonate. So check the bicarbonate value. The bicarbonate value that is given to you here is 35. What is a normal bicarbonate? 21 to 27. Here it is high. Do you see a compensation? Yes, I see a compensation. So what is your diagnosis, everybody? Can you all answer? The diagnosis is very good. Good, Uma Shankar. Yes, the diagnosis is respiratory acidosis with metabolic compensation. Right? What is your diagnosis? Your diagnosis is respiratory acidosis with metabolic compensation. That is the perfect answer. Okay. So that is all about ADG. Okay. And then the second topic that I showed you is pyloric stenosis. I've seen 4 MCQs. When I checked the last 5-year paper, I saw 4 times pyloric stenosis. Okay. So what is so special about pyloric stenosis? It is extensive vomiting, projectile vomiting, right? So whenever there is vomiting, what do you expect? Whenever there is vomiting, what is lost? Chloride is lost, right? Whenever chloride is lost, JG apparatus is stimulated. So the one electrolyte abnormality that you see in vomiting is hypochloremia, because chloride is lost as gastric acid. And this hypochloremia stimulates JG apparatus. JG apparatus produces renin. Renin produces angiotensin 2. Right? Renin produces angiotensin 2. Angiotensin 2 causes aldosterone secretion. So what does aldosterone do? All of you tell me. Aldosterone acts on the, very good student life, excellent. So aldosterone acts on the distal convoluted tubule, wherein what does it do? It causes sodium and water reabsorption. I don't want my vomiting patient to present with loss of all water, with loss of all sodium. So I'm reabsorbing it. Do you understand this? So aldosterone causes sodium and water reabsorption, but it reciprocally causes potassium and H plus secretion. So what is getting secreted? Potassium and H plus are getting secreted into the urine. When potassium gets secreted, what would you see? Hypokalemia. There is not only hypochloremia, there is also hypokalemia. Because H plus is getting secreted, there is metabolic alkalosis. Yeah, there is metabolic alkalosis. So can you all summarize and tell me what are the electrolyte abnormalities that you see in a patient with vomiting? Severe vomiting causes hypochloremia, hypokalemia, metabolic alkalosis. Are you clear? Hypochloremia, hypokalemia, metabolic alkalosis. All of you listen to me. Vomiting causes metabolic alkalosis. Diarrhea causes normal anion gap metabolic acidosis. Okay? Okay. So the next one is about hyperventilation. So what is that they ask about hyperventilation? They always say hyperventilation presents with carpopedal spasm. It presents with carpopedal spasm. Why? Right? The answer is, it is because of low ionized calcium. Do you understand this? What is the reasons? Because of low ionized calcium. So what does it mean? First tell me, when somebody hyperventilates, the person washes away carbon dioxide. So whenever carbon dioxide is washed out, an acid is washed out. If an acid is washed out, that causes respiratory alkalosis. So what we know already is, we know that hyperventilation causes respiratory alkalosis. But why should that cause carpopedal spasm? It's because the total calcium that is present in your blood, the total calcium that is present is in 2 forms. One is free calcium, the other one is bound calcium. Okay, what do I mean by bound calcium? It is a calcium that is bound to anions. Calcium is positively charged, so it's bound to inorganic anions. Or the calcium is bound to plasma proteins. Do you understand this? So what is that? The total calcium that you measure. You must have always learned that normal total calcium is 9 to 11 milligram per deciliter. Right? Normal total calcium is 9 to 11 milligram per deciliter. That total calcium exists in two forms. One is free calcium. The other one is bound calcium. Bound calcium is the calcium that is bound to inorganic anions like phosphate, or the calcium that is bound to plasma proteins. And out of these forms, it is the free calcium which is the functional form of calcium. Do you understand this? Free calcium is the functional form of calcium which maintains the resting membrane potential. What is its function? It is to maintain the resting membrane potential. Now, in a person who is hyperventilating, there is alkalosis, and because of this alkalotic pH, all plasma proteins start acting as buffers. You must have learned multiple times that proteins are plasma buffers. So what do these buffers try to do? They try to buffer the alkalotic pH. How can they buffer the alkalotic pH? By giving off their H+. To neutralize the alkalotic pH in the plasma, what do these proteins do? These proteins give off their hydrogen ions. When they give off their hydrogen ions, they become negatively charged. So all of you remember, in alkalotic pH, all your proteins are more negatively charged. When they are more negatively charged, they bound to calcium more. Do you understand this? They bound to calcium more. So for a given total calcium, there is nothing to change the total calcium. For a given total calcium, bound fraction increases. When the total calcium is the same, and if bound fraction increases, the free calcium decreases. Do you understand this? The free calcium decreases. When ionized or free calcium decreases, resting membrane potential is not maintained. So resting membrane potential is brought to the threshold potential. Action potentials are generated. All cells are hyperactive. Right? All cells are hyperactive. Neurons are hyperactive. Muscles are hyperactive. Because muscles are hyperactive, you see carpopedal spasm. Do you understand this? So all of you, can you tell me? Good, Juma. So do you all understand why you see carpopedal spasm? Everybody, right? Every medico knows that whenever there is alkalosis, there is carpopedal spasm, but you should know why, right? Do you know the reason? What is the reason? Whenever there is alkalotic pH, proteins neutralize the alkalotic pH by giving off their H+. When they give off their H+, all proteins are negatively charged. When proteins are negatively charged, more calcium would bind to proteins. So for the given total calcium, when bound fraction increases, free calcium decreases. Free calcium is the functional form of calcium. When that decreases, resting membrane potential is not maintained. Action potentials are generated. Muscle is hyperactive. That causes carpopedal spasm. Do you get it? Yeah. So this is what you need to know. So tell me, what is the reason for carpopedal spasm and hyperventilation? It is because of alkalotic pH causing a decrease in ionized calcium. Okay, the total calcium is the same. Now, clinical biochemistry starvation. I'm going to quickly skip through this because we have discussed about this n number of times. Right? I've told you stage wise what happens in starvation. I want you to remember two facts here which have been asked before as MCQs. One fact is till when liver glycogenolysis. Till when liver glycogenolysis maintains blood glucose. Till the first 12 to 18 hours, liver glycogenolysis maintains a blood glucose. After 18 hours, it is gluconeogenesis. One fact. The other fact. What is the primary source of fuel for brain? What is the primary source of fuel for brain after 72 hours? Right? After 72 hours, it is ketone bodies. Okay, after 72 hours, it is ketone bodies. Okay, so these are the facts that you should remember, which has been previously asked as MCQs. as far as starvation is concerned. Okay. And then about alcoholism. As far as alcoholism is concerned, what are the facts that you should remember? You should remember that an alcoholic is always in a high NADH-NAD ratio. An alcoholic is always in a high NADH-NAD ratio. An alcoholic is always in a high ATP-ADP ratio. Okay. Because of high NADH-NAD ratio, gluconeogenesis is suppressed. Because gluconeogenesis is suppressed, they are susceptible to repeated episodes of hypoglycemia. Do you all understand this? In a chronic alcoholic, you see high NADH-NAD ratio that suppresses gluconeogenesis, that makes them more prone to develop hypoglycemia. When there is high ATP-ADP ratio, because there is high energy, they skip meals. Because they skip meals, they are prone to essential micronutrient deficiencies. So multiple micronutrient deficiencies are common, including thiamine deficiency. And when will you suspect thiamine deficiency? Whenever they say a chronic alcoholic presents with neurological manifestations. It is thiamine deficiency which presents itself as dry beriberi. Okay. Acute thiamine deficiency, what is it called as? Wernicke's encephalopathy. So tell me, what is a mnemonic? It's a repetition for all of you. Please repeat it. What is a mnemonic I gave for Wernicke's encephalopathy? GOA. What does GOA stand for? Global confusion, ophthalmoplegia and ataxia. At the same time, please remember, global confusion is also a feature of delirium tremens. Are you listening? Global confusion is also a feature of delirium tremens. So just because the history says there is a chronic alcoholic and there is global confusion, don't go and choose Wernicke's encephalopathy. Global confusion is a common feature for both Wernicke's encephalopathy and delirium tremens. That is why reading the entire stem is important. Right? If you read the stem of the question, the stem would say that the person has withdrawn from alcohol. The stem would say the person has withdrawn from alcohol for 48 hours. So whenever there is alcohol withdrawal followed by global confusion and tremors, go for delirium tremens. No alcohol withdrawal, chronic alcoholic, global confusion, ophthalmoplegia, ataxia, that is Wernicke's encephalopathy. Okay. And apart from this, also remember they present with lactic acidosis. I don't think I will be able to explain that, Gauri. I recommend that you watch LRR session to understand that, because I'm already lagging behind, because I said I'm going to show you video, right? Video based question. That's more important because it's new and that I've never discussed, and I would prefer to discuss that today. Okay. And please watch LRR session, you will find it. Okay. So lactic acidosis, they present with hyperuricemia. So these are the facts that you should remember as far as alcoholism is concerned. Okay. So these are distractors, right? These are distractors which can distract you and make and can cause you to commit mistakes. So these are the facts that you should keep revising. Okay. So that is about clinical biochemistry. Okay. So we are done with 2 topics, right? We are done with IEM. We are done 3 topics. IEM, we are done with vitamins and micronutrients. We are done with clinical biochemistry. Okay. So now about lipids and genetics, right? So first I'm going to tell you about lipids, and in lipids I'm going to only tell you about distractors. Okay. So what should you check? Whenever they give you case-based MCQ and they're asking you to find out which type of hyperlipoproteinemia it is, right? A question is given, case-based question is given, which type of hyperlipoproteinemia it is the question. Now read the question and find out whether they have given tendon xanthomas or eruptive xanthomas, right? What should you check? Please check if the history says that there are tendon xanthomas or eruptive xanthomas. How does that help you? If there is tendon xanthoma, it is hypercholesterolemia. Okay. If there is eruptive xanthoma, that is hypertriglyceridemia. Are you clear? Tendon xanthomas is hypercholesterolemia. Eruptive xanthomas is hypertriglyceridemia. If it is hypercholesterolemia, it is type 2A. Are you clear? Hypercholesterolemia is type 2A. That is why type 2A is otherwise called as familial hypercholesterolemia. Type 2A is otherwise called as familial hypercholesterolemia. If there is elevation of triglyceride, right, it can be 3 conditions: type 1, type 4, type 5. Hypertriglyceridemia can be type 1, type 4, type 5. Okay. When will you call it as type 1? If they say eruptive xanthoma, hypertriglyceridemia, and chylomicron levels are high. Okay, chylomicron levels are high. That is type 1. Okay. Hypertriglyceridemia with VLDL level being elevated. If VLDL level is elevated with hypertriglyceridemia, that is type 4. Okay. If they say there is an elevation of both chylomicron and VLDL, elevation of both chylomicron and VLDL, that is type 5. Are you clear? So these are the classical features that you should remember in your mind and should keep revising. So what did I tell you? In clinical biochemistry MCQ, look at the stem. If the stem says it is tendon xanthomas, it is hypercholesterolemia type 2A. If it says eruptive xanthomas, it is hypertriglyceridemia, which is 1, 4, and 5. How will you differentiate 1, 4, and 5? Only chylomicron is elevated in type 1. Only VLDL is elevated in type 4. Both chylomicron and VLDL are elevated in type 5. Okay. Another possibility of case-based MCQ in dyslipidemia is grayish-orange tonsils. So whenever they say grayish-orange tonsils with low HDL, okay, grayish-orange tonsils with low HDL, what is your diagnosis? That is Tanger's disease. Yeah, that is Tanger's disease. I've told you a clue here. Tang, the most popular flavor, right? The most popular flavor in Tang juice is orange. So Tanger's disease, grayish orange tonsils with low HDL, okay, caused by the defect of ATP binding cassette transporter 1. Caused by the defect of ATP binding cassette transporter 1. So image based question, grayish orange tonsil, it is Tanger's disease. Okay. The next one I already told you. What did I tell you? In type 1, chylomicron is elevated. In type 4, VLDL is elevated. In type 5, both are elevated. Okay. So that's about dyslipidemia. Now about genetics, right? So in genetics, what you should remember, they always ask you about xeroderma pigmentosa. They've asked you this thrice in the last 5 years, thrice. So xeroderma pigmentosa, okay, that is caused by the defect of, in xeroderma there is an X. It is caused by the defect of nucleotide excision repair. It is caused by the defect of nucleotide excision repair. This has been frequently asked. Okay, that's about xeroderma pigmentosa. And in case they ask you about HNPCC, how would I ask you to remember? Double C, double M. Caused by the defect of mismatch repair. Hereditary non-polyposis colon cancer caused by the defect of mismatch repair. That's about DNA repair defects. And then as I told you, Marfan syndrome. They've asked you Marfan syndrome twice in the last 5 years. And the history has always been the same. And one tall person with long arm span with ectopia lentis, infranasal dislocation of lens, aortic dissection, right? In that case, what is your diagnosis? Marfan syndrome caused by the defect of fibrillin 1 gene present in chromosome 15. Yeah, fibrillin 1 gene present in chromosome 15. Okay. Apart from this, they've always asked you about RT-PCR and real-time PCR. right? You should know about RT-PCR and real-time PCR. What is RT-PCR? RT-PCR is reverse transcriptase PCR. What is RT-PCR? It is reverse transcriptase PCR, which helps in the conversion of RNA to DNA. It helps in the conversion of RNA to DNA. So whenever the nucleic acid of interest to use RNA, RNAs cannot be directly amplified. RNAs cannot be directly quantified. Okay, RNAs cannot be directly sequenced. So whenever the nucleic acid of interest use an RNA like SARS-CoV-2 diagnosis, it has to be subjected to reverse transcriptase PCR, wherein all that you do is you convert RNA to DNA. That reverse transcriptase PCR is called as RT-PCR. Whereas what is real-time PCR? Real-time PCR is otherwise called as qPCR, right? Real-time PCR is otherwise called as qPCR or quantitative PCR. It is qPCR or quantitative PCR, which is used for quantifying nucleic acid, right? It's used for quantifying nucleic acid. And they've asked you about CyberGreen. For real-time PCR, they've asked you about CyberGreen and TACMan probe. Okay, CyberGreen and TACMan probe. These are used for real-time PCR or quantitative PCR. Are you clear about these differences? Don't get confused on the day of exam. RT-PCR for all practical purposes is RT-PCR is reverse transcriptase PCR, which converts RNA to DNA. Real-time PCR is not RT-PCR. Real-time PCR is quantitative PCR, which is used for quantifying nucleic acid. And in real-time PCR, you use CyberGreen or you use TACMan probe. Got it? Okay, so this is one fact. And the other fact is fish. Okay, so what has been always asked about fish? Please remember, fish cannot be used for diagnosing point mutations. Are you clear? Fish cannot be used to diagnose point mutation. Fish is used only for chromosomal aberrations. Are you clear? It is used only to diagnose what? Chromosomal aberrations. What do you mean by chromosomal aberrations? At a chromosomal level, okay, to detect trisomy 21. Copy number variation like Down syndrome, right? Or trisomy 18. That can be done using fish. Or at chromosomal level to detect translocation. Yeah, to detect translocation, you can use fish. If you want to diagnose micro deletion at chromosomal level, you can use fish. Do you all understand this? So tell me, what is that you should remember about fish? I want you to know that fish is used for chromosomal aberrations like copy number variation, trisomy 21, trisomy 18, or for structural alteration like translocation, or for diagnosing microdeletion and amplification. Not at the nucleotide sequence level. Point mutation is at the nucleotide sequence level that cannot be detected by fish. So till now they've asked about fish twice. Both the times the question has been the same. Fish cannot be used to diagnose what? It cannot be used to diagnose point mutations. Do you understand this? So that is about fish. And then about PCR, right? So polymerase chain reaction, they always ask you about steps of PCR. Right? So what are the steps of PCR that they've asked you about? The 3 steps of PCR are denaturation, annealing, and elongation. So tell me, what are the 3 steps of PCR? The 3 steps of PCR are denaturation, annealing, elongation. Denaturation is carried out at 94 or 95 degree. Denaturation is carried out at 94 or 95 degree. Annealing is carried out at 5 degrees less than the melting temperature of your primers. Annealing is carried out at what temperature, all of you? 5 degrees less than the melting temperature of your primers. Elongation is carried out at 72 degree. Do you get it? Elongation is carried out at 72 degree. Right? So these are the facts that you need to remember. denaturation 95, annealing 5 degrees less than the melting temperature, elongation is 72 degree. Okay. Another fact about PCR is in PCR, in every cycle, the number is doubled. Right? In PCR, in every cycle, the number is doubled. So in the first cycle, say in nth cycle, okay, you have X number of products. In n plus 1 cycle, you have 2x products. Do you understand this? On every cycle, the number of copies doubled. So remember that. So these are the facts that you need to remember as far as genetics is concerned. Okay. Now, quickly about clue grids. Okay. So these important topics, there are a few clue grids that you should remember. Okay. To be able to answer case-based MCQs or image-based MCQs. Okay. So let's fill up this table. Okay. This you know already. Can we have a quick recap on this? Yeah, I want you to answer this. Tay-Sachs disease. Please tell me what is the hallmark clue that you will look for to make a diagnosis of Tay-Sachs. Cherry red spot, please answer. With neurological involvement, no organomegaly. Right? That is Tay-Sachs disease. And which enzyme defect causes Tay-Sachs disease? Tay-Sachs disease is caused by the defect of hexosaminidase A. Right? Tay-Sachs is caused by the defect of hexosaminidase A. And it acts on, right? So hexosaminidase A defect causes accumulation of GM2 ganglioside. That is why Tay-Sachs is otherwise called as GM2 gangliosidosis. Yeah, that is why it's called as GM2 gangliosidosis. And what is the differentiating feature? The differentiating feature for Tay-Sachs is no organomegaly. Right? And I said if there is organomegaly, it is Niemann-Pick. Okay. Now about Gaucher's disease. So all of you tell me about Gaucher's disease. What is the hallmark clue? The hallmark clue is anemia, thrombocytopenia, right? Anemia, thrombocytopenia with organomegaly. And then as I told you, there will be crumpled tissue paper appearance. Okay, crumpled tissue paper appearance with bony pain. So these are the hallmark clues that you should look for to make a diagnosis of Gaucher's. Okay, which enzyme defect causes Gaucher's? Gaucher's is caused by the defect of beta-glucosidase. And the substrate which accumulates in Gaucher's is cerebroside. Yeah, the substrate that accumulates in Gaucher's is cerebroside or beta-glucosyl cerebroside. Okay, differentiating feature. The differentiating feature would be Erlen-Meyer-Flass deformity, crumpled tissue paper appearance. Okay, so that is about Gaucher's disease. All of you tell me about Hurler's. What is the hallmark clue for Hurler's? Gargoylism, right? Along with gargoylism, corneal clouding. Gargoylism with corneal clouding with organomegaly. That is Hurler's. So tell me which enzyme defect causes Hurler's. I told you. Hurler's is mucopolysaccharidosis type 1. One is I. It is L-iduronidase defect. Right? L-iduronidase defect. Which substrate accumulates in Hurler's? When iduronidase is defective, I've told you iduronic acid is present in heparin sulfate and dermatan sulfate. Right? Heparin sulfate and dermatan sulfate. So the substrate that accumulates in Hurler's is heparin sulfate and dermatan sulfate. The differentiating feature is presence of corneal clouding will differentiate it from Hunter's. Presence of inguinal hernia will differentiate it from Hunter's. Okay. Now tell me about Pompey's. Nothing new. I'm just helping you to revise. Okay. So Pompey's, the pump is affected, heart is affected. So what would you see? Cardiomegaly with floppy baby. Right? Cardiomegaly with floppy baby. Which enzyme defect causes Pompey's? Pompey's is caused by the defect of alpha glucosidase. Which substrate accumulates in Pompe's? Pompe's is a glycogen storage disorder. Right? Pompe's is a glycogen storage disorder. So the substrate that accumulates in this condition is glycogen. Okay. Differentiating feature, floppy baby with cardiomegaly. Right? Differentiating feature is floppy baby with cardiomegaly. Sometimes they also give you macroglossia. Right? Sometimes they also give you macroglossia. That is about Pompe's disease. Phenylketonuria, hallmark. If it is dihydrobiopterin reductase defect, I would go and look for mental retardation, hypopigmentation, mousy odor with seizures. Right? Mousy odor with seizures. That is phenylketonuria due to dihydrobiopterin reductase defect. And which enzyme defect causes this? Dihydrobiopterin reductase defect. Which substrate accumulates? Phenylalanine, phenylpyruvate, phenylactate, phenylacetate. Right? Phenylalanine, phenylpyruvate, phenylactate, phenylacetate. So all these accumulate as substrates in this condition. Differentiating feature is from classical phenylketonuria. The differentiating feature here is presence of seizures, presence of neurological manifestations. Okay. The last one, alkaptonuria. Hallmark, urine turns dark on standing. Right? Urine turns dark on standing. And I also told you there is ochronosis. Okay. Which enzyme defect causes alkaptonuria? You already answered this. The enzyme defect is homogentisate oxidase. Which substrate accumulates? Homogentisic acid accumulates. The differentiating feature, urine turning dark on standing. Right? Urine turning dark on standing is a differentiating feature for alkaptonuria. Okay. So that is about the clue grid for inborn errors of metabolism. Okay. And then about micronutrients. As far as micronutrient is concerned. So before this, please look at these images. Right. So these can be asked as image based question. Whenever you see a blue color cell with crumpled tissue, that is crumpled tissue paper appearance, Gaucher's cell, Gaucher's disease, beta glucosyl cerebrosidase defect. Cherry red spot, it is not always Tay-Sachs, right? So cherry red spots are seen in glycosphingolipidosis. It is seen in lipid storage disorders, right? Seen in lipid storage disorders. And I've told you cherry red spots are not seen in. Among glycosphingolipidosis, cherry red spots are not seen in KGFM. What does KGFM stand for? Krabs disease, Gaucher's disease, Fabry's disease, metachromatic leukodystrophy. Right? Cherry red spots are not seen in which glycosphingolipidosis? Krabs disease, Gaucher's disease, Fabry's disease, and metachromatic leukodystrophy. So whenever you see this in the image, you're going to exclude these 4 disorders. Okay. Now, floppy baby with cardiomegaly. Right? Floppy baby with cardiomegaly is, what is the diagnosis, all of you? Very good, Neeraj Raghav. Congratulations for passing FMG. I'm very happy for you. Yeah. So, floppy baby with cardiomegaly is Pompe's disease caused by the defect of alpha glucosidase. Okay. Now, vitamin clue, right? So, summary of vitamin clue. As far as micronutrients are concerned, we should focus on diet clue, right? You should focus on diet clue. So, I'm going to write down only that for this table because the remaining we have already discussed. Okay. For niacin, what is the diet clue that you can expect? For niacin, what is the diet clue? I told you maize-based diet, right? Or sorghum-based diet. Whenever the diet history says maize-based diet or sorghum-based diet, think of 3 Ds of pellagra caused by niacin deficiency. Okay. Vitamin C. Vitamin C is rich in fruits. Okay. So whenever they say a person is on junk food, the person does not take fruits, right? Does not take fruits. Then you can suspect vitamin C deficiency. Please tell me for B12, what is a dietary clue that you will look for? Veganism or a strict vegetarian. For biotin deficiency, what is the dietary history? Intake of raw eggs, right? Intake of raw egg can cause biotin deficiency. For vitamin K, it is not diet per se. It can be fat malabsorption history, right? They often give you a history of fat malabsorption. They say cholestasis, greasy, thick, greasy stools which stick to the pan. Okay, so fat malabsorption. Or they say cystic fibrosis, presenting with bleeding. So suspect vitamin K deficiency. I hope you all remember vitamin A, D, E, K, right? A, D, E, K or fat soluble vitamins. And all these fat soluble vitamin deficiencies are observed whenever there is fat malabsorption. So whenever the history says fat malabsorption, suspect deficiency of these fat soluble vitamins. Okay, zinc. Again, it is not dietary history per se. For zinc, they can say diarrhea. Okay, diarrhea plus periorificial dermatitis with alopecia. Then you suspect zinc deficiency, zinc malabsorption, acrodermatitis enteropathica. Okay, so that's about vitamin clue. Okay, now images, right? Images for vitamin. So whenever you see superficial bleeding, right, petechiae, superficial bleeding, then that is vitamin C deficiency. Or gum bleeding, it is vitamin C deficiency or scurvy. And what is this? This is phrenoderma, follicular hyperkeratosis, right? Phrenoderma, follicular hyperkeratosis is vitamin A deficiency. Okay. And then if they show you knock knees, bow legs, okay. Along with that, they say calcium level is normal. Listen to this. Calcium level is normal. PTH level is normal. Vitamin D level is also normal. Okay. And they are saying low phosphate level. Everything is normal, low phosphate. It is hypophosphatemic rickets. Right? Hypophosphatemic rickets, which is X-linked dominant. Right? Which is X-linked dominant. So knock knee, bow leg in a child with everything normal, calcium normal, vitamin D normal, calcium normal, vitamin D normal, parathormone normal. But only phosphate levels are low, that is hypophosphatemic ricket, which is X-linked dominant. Okay. Yes, FEX gene mutation. So that is about those topics and subtopics that you should learn and remember the day before exam. Okay, now to summarize and tell you about strategies. Okay, how are we going to approach the various types of MCQs that are being asked? And I'm going to first tell you the strategy that you need to follow for a case-based MCQ. Okay, so for answering a case-based MCQ, there is a step 0. Okay, totally there are 5 steps, step 1 till step 5, but there is a step 0. Step 0 is don't panic. Do you understand this? Don't panic. Case-based MCQ is a blessing in disguise. Do you understand? It's a blessing in disguise because in a case-based MCQ, there'll be lots of clues. Using those clues, you can exclude at least 2 choices. So be happy when you see a case-based MCQ. That is step number 0. Okay. Now, what is step 1? Step 1 is, I know you have been always taught, right? You have been always taught or told to look for clues, characteristic phrases or catchy phrases to arrive at a possible answer. Please don't do that. Do you understand this? Don't do that. Step number 1 is look at the stem of the question. Don't look at choices first. Look at the stem of the question. In the stem, first read what have they asked. What do I mean by what have they asked? Have they asked me to make a diagnosis? Or have they given the diagnosis and then they're asking you something about the diagnosis? So what have they asked? Are they asking me to diagnose the condition? Are they asking me which enzyme defect causes the diagnosis? Are they asking me about some feature of the diagnosis which they have already given? Or are they asking me about management? Right? Maximally, these are the possibilities. So first read that part. The last part of the stem will be the question, the actual question. Read it. They might ask you which accumulates in this condition, which means they've given you the diagnosis before, which means you don't have to even look at those features, right? You have to know what is the diagnosis. In this diagnosis, what would accumulate. So always read that part of the stem. So what is step number 1 for case-based MCQ? Look at the stem of the question. In the stem, read what have they asked. Have they asked the diagnosis? Have they asked the enzyme defect? Have they asked me for management? Have they asked me about one feature of the disease? What exactly are they testing me on? Read it, okay? And then read the entire stem. Don't even leave one word. Do you understand this? Read the entire stem. Don't even leave one word and summarize positive findings. When I say positive findings, a positive finding can be there is fasting hypoglycemia, there is organomegaly, or there is cherry red spot, right? So these are all positive findings. So read the entire stem, summarize positive findings, okay? And then among the positive findings, check if there are characteristic clues. Among these positive findings, check if there are characteristic clues. For example, if one of the findings is global confusion, right? If one of the findings is global confusion, that's a catchy phrase that you know. Or if the classical finding, classical clue is Erlen-Meyer-Flask deformity, or it is crumpled tissue paper appearance, right? So these are all, or cherry red spot. So these are all pathognomonic findings or hallmark clues, okay? Or it can be palmar eruptive xanthomas, right? Or it can be a broad beta band on lipoprotein electrophoresis. So whenever you see palmar eruptive xanthomas with broad beta band, you know the diagnosis is type 3. Okay, so these are called as hallmark clues, characteristic catchy phrases. Find if there is something, okay? And then look at the choices, exclude choices. So once you have done these 3 steps, at least 2 choices you will be able to exclude. Do you understand this? Exclude choices. You will be able to exclude at least 2 choices. And you will be left with 2 choices which are very closely resembling with each other. For example, finally you will end up with Hunter's and Hurler's. Or you would end up with von Gierke's disease and Her's disease. Something which is very similar. So ultimately you will end up with 2 choices. And for finding out which is the right answer, then you will have to find out the differentiating feature which I told you in that table. So to finally find out the right answer, apply the differentiating feature that you have learnt, right? So like corneal clouding. If you see corneal clouding, you know it is Hurler's. It's not Hunter's. Do you get it? And if they say no organomegaly, you know it is Tay-Sachs. So that is the last step. Are you clear about this? So tell me, what will you do whenever it's a case-based MCQ? What is step number 0? Relax. Okay. Step number 0, relax. Don't panic. You will be able to find out the right answer. Okay. Step number 1, find out the question. Step number 2, read the entire stem, summarize positive findings. Step number 3, among the positive findings, what are the characteristic pathognomonic findings? Okay, exclude as many choices as possible. You're left with, if you're left with 2 choices, then use your intelligent guess, right? Use your intelligent guess to arrive at a final answer. Okay, please do that. Okay, so this is about, yeah, because this time you have enough time, right? Right? This time it is not like you have 72 seconds for every MCQ. And this, all these 5 steps can be done within 60 seconds. It can be done within 60 seconds. So don't keep jumping from one MCQ to another. Don't keep marking everything for review. And at the end, your brain will be like too exhausted to think, right? So as you're going through the exam, try to solve as many MCQs as possible. Be mindful. Okay, exclude choices, arrive at a possible right answer. Okay. Yes, good luck everybody. Um, Now, what if it's image-based question? Okay, if it's image-based question, similar to case-based MCQ, but here there are 4 steps. Okay, so step number 1 is look at the image, find out what the image is all about, right? The image can be a graph, or it can be a crystal, right? Urinary crystal, or it can be a clinical finding, or it can be histopathological slide. So first, just have a look at the image, even if you don't know what the image is, okay? Don't immediately start panicking. Then read the question, okay? Find the link between the two, okay? So what are the 4 steps that you need to follow for image-based question? Step number 1, look at the image, find out what image is it. Is it a graph? Is it a crystal image, or is it a fundus photograph, or is it an X-ray? So have a look at it, okay? Many a times you will not know what it is, okay? That's applicable to everybody, okay? Now, step number 2 is integrate it with the stem, right? Integrate it with the stem of the question. The stem is going to have many pathognomonic findings. The stem is going to have many pathognomonic findings which you can link here. This is possible only when the image is a support image. For all case-based MCQ, image will be a support image, in which case linking it with the stem will help you to find out the right answer. But sometimes image will be the central part of the MCQ. For example, they give you a graph, right? They give you a graph. Michaelis-Menten, no, double reciprocal plot is given. In that case, you cannot find out many clues from the stem of the question. In that case, you go back to the graph, look at the graph, okay? If it's a graph, again, even if it's a graph that you have never seen, right? Even if it's a graph that you have never seen, check what is along x-axis, check what is along y-axis. That understanding by itself will help you to answer many of the MCQs. Do you understand this? Find out what is along x-axis, what is along y-axis. Try to apply your logic, do some intelligent guesses, and try to find out the right answer. Okay, so if it's a support image, integrating it with the stem will help. If it's a central part of the MCQ, then look at the image, try to arrive at many a times in the image there will be clues. Okay, so be mindful when you look at the image and find out the right answer. Always match with the biochemical pattern at the end. Okay, so the one theme that you should always have during the exam, right, is to be mindful. Okay, is to be mindful. Anxiety reduces productivity. So at no point during the exam, you're going to allow yourself to be anxious. Keep thinking, right? Keep thinking that you have achieved already. You have done your MBBS, you have finished your FMG exam, you have done a major part for your life, okay? Whatever you're doing now is only adding a cream on top of it, right? You're adding a cream on top of it. You will be successful in life. Keep saying that to yourself, okay? No anxiety, okay? So that's about approaching image-based MCQ. Now, right? Video-based MCQs. For video-based MCQs, I'm not going to tell you what to do, okay? It is no different. It is no different from what you have to do for an image-based question. Look at the video, read the stem, find out the link, and find out the right answer. Okay, and what are the possible videos that can be asked as far as biochemistry is concerned? Okay, I have given you few examples. Okay, they can ask you videos based on clinical cases, right? Clinical cases where I told you B12 deficiency is a possibility. In B12 deficiency, they can show you the gait, they can show you the Babinski sign, and then they can show you macrocytic anemia, ask you for a diagnosis. Or it can be a Lesch-Nyhan syndrome where they are showing a self-mutilating child. Okay, chorioathetosis, that is Lesch-Nyhan syndrome. Or it can be biotin deficiency, wherein they are showing a gym trainer who's drinking raw egg, right? A gym trainer drinking a raw egg with alopecia hair loss. So that is biotin deficiency. Or they can show you a floppy baby, right? I told you, right? They can show you an absent reflex, absent parachute reflex with cardiomegaly, that is Pompey's disease. So these are the 4 cases that are possible. But what I am envisaging is If they want to ask a video-based question in biochemistry, it can be clinical biochemistry based. And in clinical biochemistry, they can ask you about order of draw, right? So which is the right order of draw? Can anybody tell me which is the right order of draw? The first blood should be into culture bottle. The first blood that is drawn should be into culture bottle. That should be followed by blue topped tubes, right? What is blue top tube? That is used for coagulation assay. Because as you know, coagulation parameters are very sensitive. So the next one has to be a blue top tube, which is for coagulation. And after this, do you all know the traffic light sequence? What is a traffic light sequence? Red, followed by yellow, followed by green. Right? Red, yellow, green. What did I tell you red top tube has? Please watch INI-CET LRR session before you go for your NEET PG exam. I've told you about all this. Okay. So red top tube has got silica, which is a clot activator. Okay. That comes first. Red, yellow, green. And yellow has silica and a gel. Okay. Yellow has silica and a gel. Green has heparin. Okay, green has heparin. That is the fifth tube. And the sixth one is EDTA tube. Okay, sixth one is EDTA. The last one has to be fluoride. Okay, EDTA. What color cap is EDTA? The color that I'm wearing today, similar to this, close to it, lavender, right? EDTA is a lavender top tube. Fluoride is a gray topped tube. Okay, fluoride is a great top tube. So all of you tell me which is the right order of draw. Can you all repeat this, everybody? What is the right order of draw? The first one is culture bottle, followed by a blue top tube for coagulation assays, followed by red, yellow, green, right? Red has got silica, yellow has got silica and gel, green has got heparin, and then it is EDTA tube, which is lavender top tube. The last one is a gray top tube, which is fluoride. Okay, this is the right order of draw. So they can show you a video wherein they are changing the sequence of order of draw and they can ask you what is the impact. Okay, or they can show you tourniquet. Tourniquet being applied for calcium estimation. Please remember, tourniquet should not be applied for calcium estimation. Otherwise, it causes false elevation of calcium. Okay, or wrong choice of tube. For troponin, wherein the analysis has to be quickly done, you will have to collect blood sample in a heparinized tube, right? Troponin estimation, you have to collect blood sample in a heparinized tube or a green top tube. By mistake, they can show you a person coming with myocardial infarction. For troponin, they are collecting blood sample in a red top tube. That is going to delay the process, right? You're going to get a result which is not of use. So these are the possibilities of videos. I've told you all these videos orally. I'm going to show you now. Okay. So can you all start answering? I'll be very happy if you keep the live chat active. Okay. So we are going to see some examples for video based question. Look at this. What do you see? Yeah, you see a person with ataxic gait who's walking. And they have also shown you Babinski's reflex being positive. That is positive when corticospinal tract is involved. Right? Very good. Good study, doc. And look at the history. A 13-year-old boy developed an unsteady gait after changing to a vegetarian diet. I told you, right? Dietary history matters. The moment you see vegetarian diet with thumping gait, okay? He had impairments in temporal and spatial orientation, calculation, short-term memory. All these are lost. And bilateral ankle clonus and Babinski sign positive, right? And what is your diagnosis, all of you? Very good. What is it? It is vitamin B12 deficiency. Okay, so this is a possible video-based MCQ. Now the next one.
Chosen.
Please check the order of draw. Red followed by blue, followed by green.
One foot front and the other, I'm thugging. Rap my Jesus, they feel like I'm bugging. Open the spirit, my face be mugging. Shooting at demons all day, we slugging. I don't do drugs, don't bring no plug-in. High in the spirit, only time I'm drugging. Bringing them back into 2000.
So what was wrong here? I am writing down the sequence. What did she collect first? She collected blood sample in a red top tube first. Okay, followed by she collected in a blue. And then she collected in green, followed by lavender, followed by grey. So what has gone wrong? What should be collected first? Blue should be collected first. Instead, she collected in red. What does red top tube have? Very good. Excellent study, doc. What does red top tube have? Silica. What is silica? Silica is a clot activator. So when a sample is collected in red first and then it is given to blue, some silica will be contaminating the blue top tube. Silica is a clot activator. When there is a clot activator, what would happen to PT and APTT? There will be falsely shortened PT and APTT. Do you all understand that? Yeah, so this is another possibility. All this is logic, right? So you need to know fact. Please remember, only when you know facts, you will be able to apply. Because you know fact, now it seems easy. But if you don't know the fact, it is not going to be easy. So do not worry about the form of question. Your responsibility is only to learn as many facts as possible. It is to understand as many concepts as possible. Once you're done with your responsibility, irrespective of the format of question, you will be able to answer anything. Do you get it? So this is a third video.
When you pick up your child, does it feel like she will slip out of your hands? Can she lift up and hold her head during tummy time? Most babies can lift their heads briefly, turning them side to side within the first month of their lives. They can typically lean on their forearms or push up from their belly at 2 to 3 months of age. This baby is an...
Very good. If parachute reflex is absent, it's a floppy baby. Right? Whenever you see floppy baby, and X-ray shows cardiomegaly. Okay, floppy baby plus cardiomegaly. What is the diagnosis? Pompey's disease. Okay, good. Now, fourth video.
His condition causes him to want to physically and emotionally hurt himself. You ready, buddy? His brain will tell him that it's going to hurt when he bites his fingers.
Can you see that he's harming himself?
Brain's also at the same time telling him that he has to bite his fingers.
The audio is not working, but if the audio
was scary at first when you read up and there's pictures of kids and
the child often bites lips, bites nails. Yeah. So chorioathetosis. What you see in this video is chorioathetosis with lips being bitten and nails being bitten. So what is it? It is Leigh-Schneidhan syndrome. So the audio is working. Oh, nice. This video is quite gross. Okay. So watch this if you can. What do you see? There is somebody who's drinking raw egg. Yeah. A man is shown consuming a beaker of a viscous uncooked liquid as part of the daily fitness routine. A habit has been following, yes. So what is it? Avidin causes biotin malabsorption. So the answer is biotin. Yeah. And finally, about strategies that need to be followed for reason assertioning type of MCQ. Okay, so always MCQ says assertion is true, but reason is false. Assertion is false, but reason is true. Both assertion and reason are true, but reason is not the correct explanation for assertion. Both are true and reason is the correct explanation for assertion. right? So these are the 4 standard choices for reason assertioning type MCQ. So I would say always start from assertion. Read the assertion, see if it's true or false. Read the assertion first, see if it's true or false individually. Read the reason, see if it's true or false individually. Then connect both these, find out if the reason is the correct explanation for assertion, and then pick the right answer. Yeah, there is no magic behind it. If you know those facts, you will be able to answer it. If you don't know those facts, you will not be able to answer it. But the clue is always start with assertion first. If assertion is wrong, then 2 of the choices can be excluded. Actually, 3 choices can be excluded. Okay. So check the assertion, find out if it's true or false, then go to reason, find out if it's true or false. Okay. Ashaya, I'm very happy to hear that. Congratulations. And this is the last slide for today. Okay. So points to remember, few takeaways. What are the takeaways? Takeaway number 1, there is a clear trend, right? There is a clear trend as far as the type of MCQ is concerned. What type of MCQ is being asked more these days? It's either case-based MCQ or image-based MCQ or integrated MCQs. These are being asked more. So if you think biochemistry is factual, then you're not on the right path. Do you understand this? You're not on the right path. It is not just about learning pathways. It's all about applying the pathway that you have learned to understand clinical conditions. Only when you do that before examination, on the day of examination, you will be able to integrate everything, because nothing will happen overnight like a miracle. So start practicing integration from today. It is never too late. You can start today. Okay. So there is a clear change in the trend of MCQ, type of MCQ that is being asked. That is my first finding. And my second finding is topics, right? There is not much of change in the type of topics that are being asked. There is a clear increase. There is clear, I won't say increase. There is a consistently high frequency of MCQ that is being asked in topic inborn error of metabolism, vitamins, right? Inborn error of metabolism, vitamins, clinical biochemistry. Okay, clinical biochemistry. There is an increase in the number of MCQ asked in genetics, lipids. Please revise dyslipidemia. Please revise glycosphingolipidosis before you go for your examination. So these are the topics that you should focus on. Okay, so these are the 5 top clusters. Okay, and for answering case-based MCQ, as I told you, follow the 5 steps that I told you. Okay, first, what have they asked you? Then read the entire stem. Summarize positive findings, exclude choices, right? If you follow that, most of the times you will be right. Okay, so to end the session, yeah, go ahead, stay confident, no anxiety. You will be able to score biochemistry, score in biochemistry. Okay, so it is not just random guessing that I want you to follow. It is always about having a method to your madness, right? It's always having a method to your madness. Preparing for NEET PG, I would say, is a mad effort. And this mad effort should have a method to it, right? So that method is what we have discovered today. Stick to it. I'm sure you will be able to come up with flying colors. Yeah. So thank you. My best wishes. Thanks, everybody.